morning, Dr. Rusty. Hi, everyone. Thanks so much for jumping on this morning. This morning, we'll be continuing our series involving AMH, and this will be part 6. So we'll dive straight into the questions. My first question for you, Dr. Rusty, this morning is, why do you need to have an AMH and AFC test before you see a fertility specialist?
Yes, hi. So yeah, today's live stream will be dedicated on use of AMH in IVF. Yeah, so everything we discussed is in the context of IVF. Previously, we discussed role of AMH in different settings. So today, everything we say is related to patients undergoing IVF and how we use AMH for that. So when you have a referral to the specialist by your GP, your fertility specialist looks at first, they look at your main fertility parameters. We call them fertility building blocks. So that's important to establish what could be the cause of your infertility. Second is what is the right treatment for you. And the third is what's your likelihood of having successful pregnancy using different methods of treatment. That's important for your specialist to know, and it's important for you to know. Yeah, so, and one of the main building blocks of your fertility is your egg reserve. So we look at the first, when we get the referral, first thing we look at is the female age. That's a very important parameter of fertility. Second, we look at the female egg reserve, which is AMH and AFC. And the third thing, we'll look at the condition of the uterus, which means whether you have any adenomyosis, severe endometriosis, fibroids, which can reduce the chance of implantation. The fourth thing, we'll look at your partner's sperm parameters. So then also we look at everything else. So looking at these 4 things, we can pretty much establish what are the best treatment options for you. And what's your likelihood of achieving success with each treatment. Then, of course, during the consultation, we go into the question of your medical history, your fertility plans. So then we build big picture about your fertility, overall health, your current fertility, we call baseline fertility, and also and big picture about your medical history and also your future fertility plans. Then we discuss different options. Of course, couples choose what option they go with, depending on the chance of success with each the different treatment options. So here the AMH is one of the main tools all fertility specialists use to formulate this treatment plans, including IVF plans.
Thank you, Dr. Rusty. And which test is more accurate, the AMH or AFC?
So both AMH and AFC have very similar accuracy in terms of telling your egg reserve. So, and in terms of their reliability, which means like their variation, they have very similar variation. So variation of AMH is approximately 30%. Let us say you did 3 AMH tests like 2-3 months apart. So in average, it should vary about 30%. In some patients, it can be more in some samples, maybe less. So generally, average variation is 30%, which means if your AMH is 10 today, after 2-3 months, it may be 12 or 13. Next time, it may be 8 or 9. So same for antral follicle count. AFC variation is approximately 30%. So they have very similar variation and very similar accuracy. So AMH is preferred because it is not subject to who is measuring, which means doesn't matter wherever you give a blood sample for AMH, they all use the same standard methods, standard AMH test, and everyone should get very similar result. So that is not operator dependent. AFC dependent on who is actually scanning you. So if you are getting scanned by expert sonographer who does fertility scans, you can rely on the AFC. If you're getting scanned by generalist sonographer, they may not be able to scan AFC properly. Why? Because AFC means how many follicles you have on your ovaries, both ovaries, less than 10 millimeters on the day of ultrasound scan. So which means the sonographer should be able to count the follicles as small as 2 millimeters. You start counting from 2 millimeters. 1 millimeter is very difficult to measure. 2 millimeter to 10 millimeter. So let us say, for example, if you have AFC of 35, which is common in patients with PCOS, you need to count 35 follicles. So that's not simple. So AFC is a subject to operator variability. Depends on who is scanning you. AMH is independent of operator, so this is why AMH is relied upon more. But we want both. We want AMH and AFC, because we want to look at AMH and AFC to have a good idea about your ovarian reserve. Generally, they should match in picomoliters. Let us say you have AMH of 15, your AFC should be 15 to 20. So if there's a huge mismatch, either you should repeat them, or you can take this into account when you're planning IVF treatment.
Thank you, Dr. Asti. Good to know that both AMH and AFC are important, but AMH is definitely very reliable and preferred. So on that, could you please explain the role of AMH in planning the IVF pathway?
Yes, so there are two things we need to distinguish: IVF pathway, IVF protocol. So IVF pathway means whole pathway to achieve successful pregnancy or pregnancies using IVF. So IVF pathway includes whole planning of IVF and what protocols you use, and when you're doing transfer, which is whether you're doing a fresh transfer or frozen transfer, and if you have any pathologies like fibroids, endometriosis, adenomyosis, polyps, treatment of those. So this is a pathway to achieve successful pregnancy. And the second thing is IVF protocol. IVF protocol means the cycle protocol to achieve ovarian stimulation. So that's part of IVF pathway. So looking at the AMH, we discuss with a couple and establish what's best pathway. Let us say, I will give you two scenarios. You have a couple who want to have 2 kids, and AMH is so low. Let us say 2.2 picomoliters. So which indicates, so they have got they got maybe only 2-3 years of functional ovarian reserve. So after first pregnancy, then by the time they come back for the second child, probably they will have run out of egg reserve. So this is pretty much the only opportunity to preserve their fertility for the second child, which means in this pathway, you discuss with the couple, if they certainly wish to have 2 kids, then they need to bank embryos first before she gets pregnant. Why? Because 9 months of pregnancy, breastfeeding, then after 2-3 years it may be too late. So this is a part of this is the role of AMH. AMH predicts how long you will have ovarian fertility. So, and yeah, in the same couple, for example, if AMH is high, AMH is 25, they don't need to worry. They just can do IVF and get pregnant quickly. Then after 2-3 years, they come back and still they have she will have a lot of high egg reserve. So this helps. And another scenario is let us say a patient has some uterine problems like fibroids, adenomyosis, endometriosis, which needs to be addressed before transfer of embryo. But AMH is very low. Let us say 1.5. So in this case, you need to prioritize embryo banking before you do the treatment, because the treatment can involve waiting time for the procedure, 6 months or longer, then recovery time. So by the time you do the treatment, then if you want to do IVF, egg reserve has dropped a lot more. So it will be harder to achieve successful pregnancy. Here, AMH level or egg reserve dictates you need to get eggs out and create the embryos and freeze, then address all the issues with the uterus. Then you don't need to worry too much about time or age effect. So AMH is a critical role to tell what is the priority: getting eggs out and creating embryos, or waiting for the surgery or optimization of the uterus, which may take 6 months, year or so, then doing IVF.
Thank you, Dr. Asti. And what is the role of AMH in the ovarian stimulation protocol?
Yeah, so the biggest role of AMH in IVF is to establish dose of ovarian stimulation. So in IVF, we want to get optimal number of eggs. An optimal number of eggs in each cycle of IVF is defined 10 to 15 total number of eggs. So it may or may not be achievable depending on egg reserve, but we try to get 10 to 15 eggs to give a good chance of successful pregnancy without increasing risk of ovarian hyperstimulation syndrome, which means we don't want to get 20-30 eggs, or reducing chance of successful pregnancy, which means we don't want to get too little number of eggs. 10-15 is most optimal. So how many eggs you get is dependent on few things. First is your baseline ovarian reserve. If you have a high egg reserve, you're likely to get high number of eggs, provided you get the right dose of stimulation. If you have a low number of eggs, low egg reserve, low AMH, low AFC, you're likely to get low number of eggs. So your egg reserve determines, and the dose of stimulation. Here, dose of stimulation means what dose of FSH you use in IVF. So in women with low egg reserve, we need to give a high dose of stimulation. Why? Because we want to activate as many eggs as we can. Let us say we have a patient with an AMH of 5, antral follicle of 8. So here, if you have a high dose of stimulation, you may be able to get 5-6 eggs. If you give a low dose of stimulation, you may get only 1 or 2 eggs. So AMH is the one tells us how much of FSH we need to use. So if you have a high egg reserve, high AMH and high AFC in PCOS, we use a low dose of stimulation. Why? If you use a high dose of stimulation, then risk of ovarian hyperstimulation syndrome increases. So it is opposite. If your AMH is low, you use a high dose of FSH, 300, 450, even like 600 units of FSH. So if your AMH is high, like in PCOS, you use a low dose of stimulation, 125, 150 units of FSH. Here, we want to get good number of eggs so that you don't need to have a repeated IVF cycles to get success. And at the same time, you reduce the risk of understimulation and reduce the risk of overstimulation. So that is the main role of AMH in IVF.
Thank you, Dr. Asti. And to conclude our live, are there any further insights that you can give our audience from AMH and AFC in IVF treatment?
Yes, rarely you see a very significant mismatch between AMH and AFC. It's not common, it's very rare. So in this condition, you have a low AMH, very high AFC. So which means per unit, each antral follicles producing a less than expected number of level of AMH. Normally, let us say if you have a AMH antral follicle count of 15 to 20, your AMH is approximately 10 to 15 around that mark of AMH. So, and in picomoliters. If your AMH is only 5, in AFC is let us say 20, that indicates follicles are producing too little level of AMH. So there's a huge mismatch, which means 2 to 3 times AFC is 2-3 times higher than AMH in picomoliters. So that indicates there's deficiency in AMH gene, in AMH receptors. Usually these genes have a relation with the FSH and LH gene. So role of FSH receptor is to respond to stimulation. Let us say you use FSH drug. Then your FSH receptor on your ovaries. So on your ovaries, you have a follicles, we call antral follicles. Yeah. On the surface of the antral follicles, you have got cells, granulosa cells, which produce AMH and which produce estrogen. Then they turn to different type of cells. Then later start producing progesterone. So those cells has got receptors for AMH, and they got receptors for FSH, and they got receptors for LH. So the role of FSH is to stimulate your ovaries. So naturally, when you're not doing IVF, naturally you produce your FSH from your pituitary gland, and that stimulates your follicle and gets to the 17, 18, 20 millimeters stage. Then your natural LH, which is produced from the pituitary, it surges and bursts that follicle. So these your hormones, natural pituitary hormones, act on those receptors. We call FSH and LH receptors. So there is a genetic variation on these receptors. Everyone doesn't have the same FSH or same LH receptor, although majority of population share very similar genes. But in the rare conditions, like where you have a deficiency in AMH, FSH, and LH, you can see huge mismatch in AMH levels. So that indicates you may have some maturation problem in IVF. Because of that, which means they may have a FSH receptor deficiency and LH receptor deficiency. For that, from the beginning, you start optimizing for that, which means you need to add additional LH hormone, for example, Luveris, or use Menopur, which is additional LH hormone. Also for the trigger, so you need to try and optimize the trigger, and so that all these receptors get activated. So, and a lot of patients, when you start with optimized protocol, not just standard protocol, you get good result. If not, then you need to optimize further. So here, when we get AMH AFC result, we look at the age, then look at the AMH, look at the AFC. So, and usually they all should match. So let us say age of 35, AMH is, let us say, 20, antral follicle count is 20, 25. That's normal. If you see mismatch, let us say AMH is only like 6, AFC is 25. So that indicates there's some genetic variation that can cause AMH receptor deficiency, and which may be linked to FSH and LH receptor deficiency. So yeah, this is not common. I don't want everyone to get alarmed. This is very rare. So, but still, we need to be aware.
Thank you, Dr. Rusty. Before I conclude this live, would you like me to ask you any of our audience's questions?
Yes, yeah, we'll have a couple of more minutes. Yes.
Yep, awesome. I'll ask 2 questions from our comment section, and also thank you so much to those that have commented a question. And if we do not ask it, we will collate these and can answer them on Dr. Rusty's TikTok and Instagram. So my first question, someone has asked, can the protection pill affect your AMH level?
No. So in the past, we didn't really understand until AMH and AFC. We started using AMH and AFC pretty much approximately 20 years ago in average. So yeah, so we thought follicles get recruited cyclically. Every month you have a new wave of follicles. So, and now we understand follicle recruitment is a continuous. It's like a river. So you have a 2 level of recruitment. One level is a continuous, like a river. Every day you're activating small follicles. Then after a few months, they are appearing as AFCs. And this level is not affected by anything. Nothing can stop, nothing can speed it up, nothing can slow it down. So, so this starts, let us say, once you start having menstrual period at the age of, let's say, 13, 14, then it stops when you have a menopause. So that's the continuous. Even in pregnancy, you keep activating. If you check AMH levels in pregnancy, you see very similar levels to while you were not pregnant. So same with AFC. So that's continuous. Pill, any other interventions does not affect that. AMH is being produced from those follicles. They're small, we call antral follicles less than 10 millimeters, and invisible preantral follicles, they produce AMH. So that level is a very static. Pill or nothing, Mirena, any other injections do not affect them. So the second level of follicle recruitment is a cyclical. You select 1 or 2 follicles because of your FSH increase after menstrual period, and one of them ovulates. So that is a cyclical. That follicle doesn't produce AMH. So that means whether you're ovulating or not, whether you stopped ovulation with a pill or not, it doesn't matter. Your AMH level, because it's being produced from antral follicles and preantral follicles, that's continuous like a river all the time there. It is not affected by any pills or any medication. Why we have a variation? There's a little bit of variation coming from the measurement. Nothing with whatever you measure in blood, it's not 100% accurate. It's very accurate, but not 100% accurate. But main variation coming is the firing of activation of eggs. So let us say every day you're firing new follicles. So we think you activate 1 egg every hour. A lot of them become disappear before they become visible. So, and then some days you may fire more follicles than other days. So this way, level of antral follicles on your ovaries can go up and down a little bit. This variation is a 30% difference every day. So then AMH they produce also can vary a little bit. So that's approximately 30%.
Thank you, Dr. Rusty. One last user question. A user has noted that they have an AMH score of 96 and they understand that this is quite high. What do you recommend that they do next?
Yeah, so it depends on their plan. So AMH of 96 picomole indication of generally PCOS. That means with very high egg reserve. So that means that possibly it may cause anovulation. So if menstrual cycle is happening every 2-3 months, that indicates the ovulation is not happening regularly. If they're trying to conceive, then ovulation induction like Clomid, letrozole, or FSH is best approach, provided they don't have any other cause of infertility. So if they're not trying to conceive, then they don't need to worry. So that's just indication of high egg reserve. If they have symptoms of PCOS, of course they have to manage those symptoms. So overall, high AMH means high egg reserve, long fertility, and late menopause.
Thank you, Dr. Asti. That does conclude our live this morning on part 6 of the AMH series in IVF. So thank you so much to everyone that jumped on and also contributing to the comment section. For those questions that weren't answered, we will collate them and we will look at answering those on Dr. Asti's TikTok and Instagram. And as always, the recording of this live will be published on Dr. Asti's TikTok, Instagram, and YouTube. We look forward to our next live. Thank you so much, Dr. Asti.
Thanks, Gabby. Thanks, everyone, for joining. Thanks for lovely messages. Thank you.
Thank you. Bye.
Thank you.